Thank you, Chad, and to everyone at his team. One line that stuck out to me so much in that was, I can make a living as well as an impact. And I think that brings us to our discussion today about making a living, but also making an impact. And I am honored to virtually sit here with you all, even though I'd much rather be in person, like Gwen said, hugging you all because I'm a hugger, our whole team is, but virtual will do for now. So I am here to facilitate this dialogue about how to truly be partners in care with three essential elements. And those elements are respect, dignity, and trust. Audience members, I welcome you to think back right now to all of your many encounters with healthcare professionals. Have they always reflected those three principles of respect, dignity, and trust? Write it in the chat. You can also tweet it. You can use our hashtag MPAF Rural Health. I would love to hear, have all of those experiences really reflected respect, dignity, and trust? Personally, speaking for myself, mine haven't. And maybe yours hasn't either, or maybe you've had great experiences, which I'm happy and I hope that you have. And I am here with a set of dynamic duos of providers and patients. And I have the honor today of sharing with you how all of them exemplify all three of those. So first we have Michael Fratkin, who is a palliative care physician in rural Northern California, and Judy Surber, a Hoopa tribal member who met Michael while he was caring for her brother and later cared for her husband. And then our other dynamic duo is Tammy Taylor, who is a cardiology nurse practitioner in the Mississippi Delta, and Jeannette Johnson, who is one of her amazing patients. And they have been partners for a couple of years now, navigating Jeannette's heart condition and diabetes. And I actually want to start with Jeannette Johnson. So Jeannette, I would like to start with you. We had a conversation earlier and you told me that Tammy really provides care for you that's holistic, you know, and even though her specialty is in cardiology, she's concerned about you as a whole person. She's helped with your diabetes, financial concerns. So tell us a little bit about the type of care she provides and how she builds that connection with you.
Good morning, everybody. I'm Jeannette, and Miss Tammy Taylor is my doctor. I met her in, I believe, 2009 when she started treating me for my diabetes. Prior to that, I had stents put in, and um, after the stents, I believe in 2014, I had to have a triple bypass surgery. But when I met Miss Taylor, I knew that she was the one for me. She was the doctor for me, and she was the one to take care of me, that was going to be taking care of me, and I would follow her anywhere she went, long as she could take care of me. I did that bypass surgery in 2014, and on the day that I got my stitches and staples taken out, I just got dropped off there at her office, and she was the one that was holding my hand. She had to get the other doctor to bring him in to help her get those stitches and staples out of me. And I told her, I said, don't take them out. They're not ready. She said, don't worry. She said, I'm gonna make sure that they're ready to be taken out before I start to take them out. And she was there holding my hand, and I was hoping that I wouldn't break her hand, because getting those stitches and staples out was very, very painful in certain places. But I was just glad to have her there, and I consider her my friend. I consider her my confidant. I consider her my therapist, and most of all, I consider her my doctor, the doctor that's taking care of me.
Yes. I love that. That is truly the definition of partnership, and that highlights all the three aspects that we talked about: respect, dignity, and trust. And now, Tammy, I would love
Yes,
for you
ma'am.
to add to that. How do you build that type of relationship? To hear Jeannette Johnson sit here and talk about you so highly, what have you done to build that? Because we have some people here who are tuning in that can use those tips and suggestions.
Good afternoon, everyone. And for me, I growing up, I was just taught the golden rule: treat people like you want to be treated. So it's not hard for me. When my patients sit in front of me, ideally I see my sister, my mother, and I just see a friend. And that's how I try to. That's how I build a relationship with my patients. So that is not hard for me at all. Growing up, I lost my father from heart disease. My dad died of a massive heart attack at the age of 46. I was in eighth grade. So I did not know that I was going to work with heart patients one day. So this is personal to me. And so I get to know my patients. I just don't, they're not a number to me. I get to know who they are, I get to know their families. And I just, and I love this statement is that people don't care about how much you know until they know you care. And so I just take that into every room that I go in, and that's just how I feel. So it for some people it's something they gotta try to pretend to be. That's just not who I am. And so she said all those kind things about me, but really I do care about what I do. And I think that in order to show that to your patient, I always say you can't give something
Thank
that you
you.
do not have. So it's been my pleasure to take care of Miss Johnson and to take care of other patients and to do all I can, because when you're treating a patient, you have to treat the whole person. And even though we specialize in cardiovascular disease, we realize that people that have hypertension, diabetes, if those different chronic conditions are not controlled, then they lead to heart disease. So with that said, it's just, I mean, I don't know any other better way to say it. It's just who I am. And, when you care about people, that's what you do. You show it.
Yes, I love that. And like you said, it's who you are, it's who you've always been, and it's who you will always be in the future. And that speaks volumes to you and how you were raised and the type of care that you provide. And it's a beautiful transition and connection to Michael Fratkin, who, shameless plug, not shameless, who was interviewed during episode number 4 of our podcast, which I'm the lovely host for. And the title of that episode is People Helping People and the Vulnerable Face of Mortality. And that title came from something that Michael said, which was he introduces him and his team as just people helping people. There's no patient or provider, there's no hierarchy. Like you mentioned, Tammy, when you sit there, you see someone that's your equal. You see your mother, your sister, your brother, your father. You see someone that you care about. And so, Michael, I think that you echo that beautifully. So can you add on to share about, what do you do specifically in your field of palliative care to build trust and respect your patients? Tell us a little bit about what you do in your practice.
Thank you so much. It starts out just with how I introduce myself. When I step into a space, what I heard just now was this paradox that the person that is sitting across from you and in need of assistance is like family, is like yourself. You relate to them. But the other side of the coin, the paradoxical truth of that is that they are an entirely other human being, a mystery, and having curiosity about who they are and earning their trust so that they can invite you into understanding what their lived experience is an area of my passion. So it all begins with, how do I introduce myself? And I do it every day in sort of the same way, by explaining to people that we don't, we don't take care of any patients. We only take care of people. And we do that with a team of other people. We bring a certain special knowledge and some deep experience in areas where people are facing mortality. But the most important thing people need to know is that we recognize that we're coming up towards them as the people we are, in addition to inviting them to share who they are. The more important person to ask that question is Judy Surber. She and I have worked close together in a couple of different scenarios. And I think that she could talk a little bit about how we bridge that gap.
So,
Yes, definitely. Judy, go ahead.
okay. So when I met Michael Fratkin, he was the caretaker for my brother who has COPD and lives next door to me. We're a very close-knit family. And at the same time, my husband was also very ill with the same diagnosis of COPD. And I watched Michael and my brother had the right insurance and me and my husband did not. And I watched Michael's team before I'd ever met him. It was like the most kindest people I've ever seen, who were coming to my brothers and advocating and so supportive. And I've met now and been in his office where there's like 20 people in one room working, and I've never seen anybody there in a negative way. Like every single person is always so upbeat and helpful and outgoing to you. And so, I wanted that kind of care for my husband at his end of life. And Michael ended up offering it to us. And there was a lot of, my husband was complex, like he had a lot of medical issues, but we also had barriers from, we're on a reservation and we're Native American. My husband had really not ever gone to doctors much. There was a lot of mistrust back from when he was little that carried over from how he was raised. And he had, like, for his age, he had a chart about this big. He didn't go to the doctor unless he literally was on his deathbed. And so Michael is so good first about listening to what kind of person. He takes a lot of time and he wanted to know his story. Where did you work? How many kids do you have? Until people feel really relaxed. And then he's always so kind and respectful. And it was just a really good connection for so many reasons. And we had the last few years of his life up to that point had been juggled and tossed around by a lot of doctors who really didn't want to care for my husband and would put him off on other people or never really took the time. I mean, this was somebody who literally was at the end of their life, and still we were having a really hard time accessing care for him or getting a doctor who felt like we even cared about what we were going through. And so he just exemplifies that completely. I don't know any patient who doesn't think that. And you might not want to have that kind of care. I mean, most people would rather be really healthy and never need palliative care. But if you ever do need palliative and end of life care, that's the kind of doctor you want. You want to feel like you're cared about. You want to feel like your family's cared about. And they didn't just go into what my husband's issues. It was always checking on me and our children and other family and what can we do. And how can we help? And I think it's done a lot to bridge into from Eureka, where his office is, to Hoopa, an hour away, the reservation I live on, and to help bridge that gap so that, you know, we really hope to get other people here receiving the same good service that we were lucky enough to get.
Yes, thank you so much, Judy. And one thing I did want to follow up asking you about is about that history of mistrust, you know, especially on the reservation, especially in your community. I know that you said in a previous conversation that we had about culture. Your culture has different traditions that a lot of doctors don't understand or accept. Can you explain a little bit about one tradition that your family had after the passing of your husband that Michael respected and embraced?
Well, so we do have, one of the things about Hoopa, our tribe, is that we weren't discovered until like in the 1850s. We're very remote, we're in the mountains, and so we have been able to keep a lot of our tradition and culture alive. It hasn't been stripped away as much as other tribes because we were late. We were found later than most tribes. When you think of other tribes found are, you know, in 1600s and 1500s, and here we were literally my great grandfather's lifetime. So we do have things that are followed in upon death, and one of those things was that when somebody passes away, you do not take them out the door. You take them out a window, because it's about the spirit going back out. And so that was one example. It's really important that we try to have the person buried within 4 days. It doesn't always happen now, but that's kind of how we do it and what we shoot for. So there's just differences. And a lot of times, and I work at a clinic, so we get a lot of locum doctors here who are just, I was watching the other lady's presentation about how hard it is to get people in rural communities, professional staff. And we definitely have that problem. So we have to depend on a lot of locum doctors. And I think when you're only seeing somebody once and then another doctor and then another doctor, you don't get to build that relationship or the understanding of each other. So that's just one example of some of the things that Dr. Fratkin was so open to and eager to learn, and, you know, respectful of how we did things, that not all doctors would just kind of brush it off, like, you know.
Yeah.
Ashley,
And that
can I
goes
add
back to
something?
Yes, of course.
Okay, it's just, thank you, Judy, for being so kind to me and so complimentary. But there's something that underlies the way that we work, which I think is really important. Most medicine is provided on a transactional basis. You do this, you get paid that. The revenue comes to support the cranking out of healthcare in pieces, transactions. But what's actually but beautiful about the economics that supports palliative care delivery by a team in people's homes is that it's not transactional, it's actually relational. I don't want to get too into the economics of things, but the idea that we get paid for the whole team to be responsive and adaptive and to work over time really changes the nature of the engagement with people. And that's where most of that warmth and relational connection that Judy describes so well emerges. It actually emerges out of the economics of how we are structured to be paid and to be sustainable.
Yes. And one thing that I would like to highlight that Judy said was this concept about having the right insurance. And Tammy, I would like to go to you because I know that you work with a lot of patients who don't have access to equitable and affordable care. So what are some solutions that you've implemented to help your the patients that you serve get access to that?
Okay, well, I'm glad you asked that. Right now, we're in the period where it's time for the Affordable Care Act. So a lot of my patients that do not have access or do not have health insurance, always tell them about this open enrollment and try to get them enrolled into some type of health care. Oftentimes people feel they can't afford health care, but I tell them to, at least go through the process to see what they can afford. And oftentimes they find out they can actually afford health care. So that's one of the things I've been doing during this period. Other ways we try to get health care is that we try to connect them with, if there's available, there's not a lot of resources in Mississippi to connect patients with. Oftentimes with us, unfortunately, we find ourselves treating patients medically, and that means medication therapy only. If we think a patient based on their diagnosis, we try to treat them just with medical therapy. And we often do that in the clinic, and sometimes have did that for almost 2 years. Sometimes we have patients diagnosed with severe cardiomyopathies, and that means they have a weak heart muscle, and they do not have any health insurance coverage. So we try to place them on affordable medications that they can afford and connect them to some of the mom and pop pharmacies that we still have, that sometimes they can get their medicine for little or nothing. So we find ourselves doing that. Sometimes we do, in the past, I have told some patients to contact PAF, the Patient Advocacy Foundation, to see if they have any resources. So those are some of the things that I try to do to assist my patients.
Yes, thank you. And I know, Jeannette Johnson, you shared that Tammy has helped you navigate those financial concerns that you have. So can you share a little bit about what that partnership has looked like and what those conversations look like for her to empower you and help you find those resources?
She's real attentive to me, and I know all the patients. I mean, all the patients sit out in the waiting room patiently waiting to see her. And if we ask her anything or say anything, she stand up and take notes. And she has directed me to places where I could get help. They the advocate that I tried to get in touch with, they couldn't help me because I had personal insurance. But she did direct me, Miss Taylor. She directed me to a mom and pop pharmacy, and one thing she told me, she said, "You don't develop a relationship with a pharmacy. You go to a pharmacy where you can afford your medicine." She did direct me to places where I can get affordable medicine. I have gone without taking medicine. I had one medicine, a diabetes medicine that was extremely high, and I think I went about 3 months without that medicine because I couldn't afford it. But she helped me get back on a plan where they would give me a coupon to get that medicine, and she gave me advice on what pharmacy to go to. Anything that she can do to help me, she has, as far as getting my medicine and making sure that I did, take the medicine. I mean, she's real good with all of her patients, and I think that's why we love her. We really appreciate her being in the position that she's, being in our lives, period, to be there for us, to take care of us. And she really she really goes out of her way to help us, whereas I have had doctors and they say, I've gone and they had chest pain and all that's just chest wall pain, but you know, if like I say, if you tell her something, she's gonna stop and listen and do her best to take care of whatever it is that you have going on with you, all your ailments, everything that if she knows something that's not right, she's gonna stop and she's gonna take notes and she's gonna take action. She's gonna do everything in her power to make sure that you're okay and that you're doing all right, because like she said, there's not much in Mississippi. If you need a specialist, you have to go at least an hour and a half away to get a procedure done. You know that's big, like the bypass surgery that I had. There's nothing in this part of Mississippi that I know of that has the equipment to do all the procedures that needed to be done to me. And like I say, if I say anything to her that needs action done, that she needs to take notice of, she does it right then and there. And because of the pandemic, when I walk in, when she walk in to see me, most of the time we hug, and it was kind of awkward the first time I went back in to see her, because she kept a distance, and I understood that, but it was awkward not getting that hug from her, because I was used to getting that hug. And most time I did need that hug, but I understood because of the pandemic that I couldn't get that hug. But that's the type of relationship that we have, that I appreciate her being there for me, and I just can't say enough about her. That I just can't say enough. I can't thank her enough because of all the care that she's given me. I think I've got a folder so big, I might have the biggest folder in her office, but she takes really, really, really good care of me, and she is a type person that, and I believe she's looking at a sister or a friend when she walk in that office to see me, and I really, really, really thank her.
And it's because of those 3 pillars that we highlighted. The title of this is the respect, dignity, and trust. And both you and Tammy talked about transportation, which is a huge barrier that we hear repeatedly when we talk about access and barriers in rural communities. So I would definitely love to switch and talk to Judy about transportation, because when we think about solutions, sometimes solutions are implemented, but not always thought out. And I know, Judy, you expressed that Indian Health Services, helps your reservation, but some of the solutions that they propose aren't always the best. So can you expound on that and then give us some suggestions for solutions that would work?
So I was listening to Jeannette talk about how they have to go 1.5 hours for specialists. And that's where we have to go just for any kind of anything. And for a specialist, we have to go 6 to 7 hours. Northern California has lost more and more, even basic specialists like ears, nose, throat, or dermatologists. So our next place to go is usually Sacramento or San Francisco. Some of them we can find in Redding, but normally we get sent to Sac or San Francisco. So we're talking a 6 to 7 hour drive. Because we're a tribal health clinic, we receive PRC money, which is patient referred care. And it's money that is to help people it's for rural reservations to help get those people to appointments and to help cover that. what I said the problem was is that so many people though don't have transportation. Like you can give me money all day long to go pay my gas and stuff to San Francisco, but if I don't have a car, or we have what we call res cars that you can just get around here, but you can't actually get over the hill to Eureka because they won't make it, they're not licensed, whatever the reason. So transportation here is a big, big barrier. I know people who have literally just not even been able to go to really important appointments because they had no way to get there. Some of us are lucky with family members who step in, but not everybody has that or has families who are able to. I think the only solution, which we used to do here like 20 years ago, was have actual transporters with vans and cars that drove people to their appointments out of the area. But I guess for financial reasons, that was stopped about 10 years ago. And so that's one thing we, like for our community here, need to look at is how to get people to appointments, not cutting a check for gas to get there, but actual transporting and getting them there.
Yes. And I love that. Like you said, you can throw money at me, but if I can't apply it, it's not really effective. And transportation, you know, is something that we see universally in a lot of rural communities. And I know that one that we spoke specifically about your reservation is substance use and how deeply rooted as a barrier that can be for multiple reasons. And you actually didn't include this in your introduction, but you're an author. And I appreciate that you write from the perspective, not your personal perspective, but, you know, the collective of people that you know, from the perspective of a substance user trying to get the care that they need in a dignified way and by being respected and being trusted. So can you expound on that and share how you highlight that perspective and how you've seen it played out in the life and the care for your husband, between your husband and Michael?
Okay. So I started writing my book I called Reservation High in 2014. And at the time, what I kept hearing from friends and family over and over was, you know, well, maybe I should just get high. Maybe I should just not have reality and have a job. And, you know, like they made it sound like it was so simple. And I can tell you that there is not a harder life than one of an addict. I know it from personal experience. I have 2 adult sons who have been really hardcore heroin addicts. One of my sons now is recovering. He's 9 months clean. One of my sons is a mess, and I pray hard every day to the Creator to some intervention. But beyond that, what people don't know about, Ashley was one of the few people I told, was that my husband was also a hardcore heroin addict. And he was one of those people who worked all his life as a logger, who supported his family, who lived such a good life taking care of us, and got in a logging accident in 1999. Had major back injuries, and which started a course of then opioids for his back pain and surgeries, and it just grew from there. It was the time that OxyContin came out, when they were saying it wasn't addictive, so doctors were pushing him on that. And it was something that I didn't even know for years. He was very discreet, he was very functional, he took care of our grandkids, and but it was a hard road. It was something he was very not proud of at all, you know. So one of the issues with healthcare is getting treatment when you have addiction. And I can truly say as a witness to this that your care really goes downhill if you have substance abuse. When my husband would be in the hospital, I would stay with him the majority of the time, even sleeping there. And every nurse and every lab person that came in wanted to give a lecture. Oh God, here's the guy who's broke his veins down. See how hard this is for us to treat you because what you've done to yourself. And it was constant put downs. It was constant dismissing, like, what's the point of helping you when you're just killing yourself? And so it got to the point where he didn't even want health care anymore because it just felt like it was like everybody was so judgmental. He told me at one point, if I have to go for a long-term thing at the hospital again, I would rather just die than go through that again. So that was an open conversation we had with Dr. Fratkin, not immediately, but at some point early on, I let him, like, we talked and I just said, this is what it is. This is what and he was just very non-judgmental and just said, it doesn't matter, like, he's at the end of life care and he should be allowed to be comfortable. And if you're willing to be honest and work with me, I will do whatever I have to do to make sure that happens. Because it's a hard road to find comfort when you have somebody who's so tolerant. What might help me isn't even going to touch his pain. And that's what we found a lot of times. Doctors weren't willing to do that extra step to see what would help him. So when we developed that relationship with Dr. Fratkin, it kind of sealed the deal where, we could be completely open and honest. Okay, he's done really well with what you've given him, but he had a relapse this day or whatever. And working together, I can say the last week was a really hard week, but my husband was able to die with respect, dignity, trust, and to not be in horrible pain. And I think it could have been a whole different outcome. I've seen different outcomes here where people really suffered. And so luckily that wasn't our case. And I do attribute that to Dr. Fratkin and our relationship and just building this relationship where there was total honesty, where we could just say, I wasn't trying to hide it, wasn't trying to cover up or, downplay it even. It was just a open relationship where we could talk freely. And in the end, it really did help my husband a lot, like be able to have a peaceful passing.
Yes. Thank you, Judy. And Michael, that takes a lot to be able to fill that role and help Judy. And she mentioned this in the beginning that her brother had the right insurance that allowed you to give him the care that he needed, but her husband didn't. But in the end, you did anyway. So can you speak to how you provide that care in spite of what an insurance is going to pay for?
I just have to say, Gordon Surber was a beautiful man, a hardworking man, a dedicated father, a dedicated grandfather. He was frustrated by anything that got in the way of his ability to help Judy take care of their incredibly complicated family. He was so much more than a guy with an illness and a set of substance use issues. He was a great guy. So I just have to say. First, I do want to just let people know what palliative care is, because people have all kinds of different ideas about what it is and what it isn't. And for me, there's just really three things that I want everybody to understand. Number one, I've already mentioned, we don't take care of any patients, we take care of only people. Number two, we're very good at symptom control, even in the complex circumstances with pre-existing social problems or substance use issues or whatever. We've got a very good bag of tricks. We know how to help people with the miseries that they experience as a result of being seriously ill. And then the third thing is we help people and their families to navigate through this crazy healthcare system that we haven't really designed, but has sort of emerged out of an industrial model of healthcare delivery in the 20th century. So palliative care is a specialty of medicine, team-based, that focuses on the quality of life that people experience as a sort of parallel path to, as an additional needed layer of support to all the disease-directed care that they're receiving. So we work in concert with, in collaboration with, in coordination with primary care providers, specialists, etc. So that's what palliative care is. And now I have forgotten your question, Ashley.
It's fine. Also, please, audience members, include your questions in the Q&A box because we will be opening that up shortly. But my question was, Michael, how were you able to provide that care for her husband, even though he didn't have the right insurance?
Well, you know, for the first few years of Resolution Care Network, we basically took everybody that came our way, whether we could get compensated or some revenue to support our work or not. And as anybody who's done anything in business, if you take in less money than you spend, well, that's not much of a future-oriented plan. So we shifted to only taking people whose health plans provided a benefit for team-based palliative care. In our world, that included the Medicaid managed care organization that Judy's brother had, right? And so we were able to provide our whole team-based care to him in his home and when he was hospitalized, and followed him to a long-term care facility for a period of time when he was recovering. And we have wrapped around Mark for a number of years. However, for people who are young and poor and very sick, well, those folks had access to us. But people who are old and poor and sick with Medicare did not, because Medicare doesn't pay for that whole team-based relational care on a going forward basis. So basically, the way that we did it for Gordon is we did it for free.
Well, that's
couldn't do that every day for everybody, right? But this
Yeah.
family became very important to me.
Yes. And that's admirable because, once again, it didn't matter what was approved or what wasn't approved. You're a person helping a person. And whether it was paid for or not, that didn't matter. And that is the highlight of the 3 pillars that we are here to talk about. And
Can I add a fourth pillar, Ashley?
Yes.
Is
Yes,
it okay? I mean, I think just spending a few minutes with everybody in this particular forum, there's a fourth pillar that is somehow or another maybe taboo, but that fourth pillar is love. The love that human beings feel for each other when they connect and see each other and hear each other is an important pillar, not just in bridging the gap between rural and urban, but bridging the gap between us and them, all the divisions that we see in our society. It seems that love has a place in healthcare as well, or at least I say so.
I agree. And the chat agrees as well.
Yay for the chat.
And now we'll open up the chat for you all to submit your questions for the Q&A portion. Because I can sit here and talk to the 4 of them for the duration of this, but
There has been
definitely
a
don't.
very exciting chat room discussion going. So I'm trying to catch up or scroll back to the beginning of where questions started. So there's one from Emmanuel to Dr. Fratkin. How can we incorporate this type of palliative care into our daily patient care instead of waiting for the end of life? Also, with your experience and how you have deployed your processes, do you have the best practices to share with primary care providers who are seeing patients daily for chronic issues?
Totally. And hello, Emmanuel. Primary care is where, I mean, to me, it's actually kind of crazy that we've made this specialty of palliative care as some like special person-centered specialty. It's crazy. Family practitioners, family nurse practitioners, physician's assistants, nurses, community health workers, people have been looking at the people they serve as whole people for generations, hundreds of years. It's only in the sort of 20th century hyper-specialization and fragmentation of healthcare that it's crazy enough to make a specialty called palliative care. Now, palliative care, by definition, can be provided at any time during a person's life. It's not just end-of-life care. We think of hospice care as being specialized for that very last chapter of life, but palliative care can really extend over the long life of a person, anyone who's really facing something serious. And when we say serious, it's a euphemism for somebody who has been made conscious of their mortality by some medical problem that they're facing, right? So primary care is really the site where all person-centered care begins. Tammy and Jeannette's conversation and the relationship they have of healing just illuminates that perfectly. So primary care, when it's not just a production-based efficiency machine, should invite that kind of connection. And maybe it doesn't take 45-minute or hour and a half encounters. Maybe it can happen more quickly with intention and direction.
Fantastic. This is another question for you and also for Dr. Tammy Taylor. How much of your practice was influenced by formal training in developing these critical person-centered communication skills? How do you suggest replicate skills development focused on the person beyond the disease for all clinicians in all disciplines?
I've thought about that question, and of course, you know, I did develop some of my skills in formal training, but I think it comes more just by lived experience and dealing with patients every day. Like I said, some things are innate qualities that you have. Some people have to learn how to communicate, and there are others that it just come more naturally. And I think for me, even though it was at some point it was taught, but not a whole lot, but just through interacting with patients day to day and from my own upbringing and from what I've dealt with in my life, it's easy to translate that into, you know, when I'm dealing with patient care. What was the other question so I can try to answer it? It was a two-part question, I think.
Yep, I had to scroll back up. How do you suggest we replicate skills development focused on the person beyond the disease for all clinicians in all disciplines?
How do we do what?
Suggest we replicate skills development focused on the person beyond the disease for all clinicians in all disciplines.
By having these type of conversations, that's it. It's I mean, when you have these type of conversations, I mean, that's the best way to you know, share with other clinicians what you're doing in hopes that they will try to you know, better, you know, to understand how to better relate to their patient. That's all I can say.
Yeah, I just want to echo what Tammy said exactly. In terms of formal training, I think the best training came from a mentor of mine, a doctor named Tom Evans, who in medical school just kept putting my face in the fire to remind him that as smart as I am and as good a student as I could be and as much as I could memorize, that the curriculum was actually happening right outside of myself, right at the edge of this interaction between someone currently engaged in a medical illness and me. Now, in this time in my life, I'm not sick, but someday I'll switch roles. And he reminded me that over and over again, that the teachers, the real mentors for me, were going to happen right there at the bedside, right there in communication with all these human beings, and that I don't know anything about their world and how they're experiencing this illness unless I ask them. And they won't tell me unless they trust me. So he put my focus on that particular place early on. And then a bunch of amazing and wonderful, extraordinary and messy people taught me what it meant to actually understand a little bit about what illness is. And what Tammy said about these kinds of environments, I'm so excited to be part of a conference around patient advocacy, even though I don't really like that word patient, because this is where the power lives. We spend, doctors and nurses, we spend all our days talking to each other all day long, every day. We go to conferences and make ourselves feel important. But it's rare to open our arms and invite the people who actually depend on us to tell us what they say is important. So this kind of an event is really important to me.